My patient for this case study development project is Gerald Goldberg. He's a 43-year-old Jewish male who uses tobacco and alcohol and sometimes uses illicit drugs such as marijuana and cocaine. He has a constantly changing work schedule, a very high-stress job that requires frequent traveling. He has trouble sleeping. He suffers from anxiety and depression. And he overall has a disregard for the importance of regular oral hygiene visits and does not have a good attitude toward oral care. Harold also presents with hypertension, trigeminal neuralgia, anxiety. He has allergies to latex and codeine. Upon taking his vitals, his blood pressure was 140/101, pulse 52, respiration 16, and temperature 98.6. He's an ASA class 2. His prior surgeries include jaw reconstruction surgery with implant placement restorations following a traumatic car accident in 2005. He was hospitalized for that. Due to complications, he received nerve block ablation in 2006 and suffered a mental health crisis in 2013. He started medications that are listed, and the major medical treatment and procedures related to this disease, trigeminal neuralgia, is from complications of the prior oral surgeries in an attempt to reconstruct his mandible. The onset of trigeminal neuralgia symptoms happen after his surgeries. The etiology is unknown, but there may be a link. So medical emergencies that we would be prepared for is orthostatic hypotension from the medications, fainting, hyperventilation, hypertension, myocardial infarction. His oral findings are xerostomia, periimplantitis, and moderate generalized periodontitis class 3 with localized aggressive periodontitis class 4 in the posterior quadrants. The medication that Harold is taking is carbamazepine for his chronic pain and TMD symptoms. He's taking 200 milligrams twice a day. While we do his nutritional counseling, we want to make sure to let him know to avoid grapefruit because it can enhance the blood serum levels of this medication. The contraindications of medication are tricyclic antidepressant, bone marrow depression, and there's a black box warning that sometimes severe and fatal skin reactions might occur. We're fortunate here that Gerald's not been prescribed tricyclic antidepressants despite his diagnosis of depression and anxiety. So the oral effects of the medication is xerostomia, swollen tongue, and mouth sores. So this is something that we should be aware of during our exam and every follow-up appointment to see if these symptoms are present. However, Gerald does already present with xerostomia, so we know that, and we'd recommend Biotine to help him with those symptoms. The medications that Gerald's taking include baclofen, which is prescribed for trigeminal neuralgia. He takes 5 milligrams 3 times a day. The concern here is that it may cause psychiatric disturbance and insomnia, polyuria, and fatigue. The patient is suffering from depression and anxiety, so this may be something that we'd be concerned about. And he's also suffering from poor sleep. This may be exacerbated by this medication. The contraindications are hypotension and hypersensitivity, so we should be aware of orthostatic hypertension during his treatment. And the oral effects is vomiting, shortness of breath. So in that case, we would be concerned about the vomiting leading to erosion, where we may consider recommending baking soda. Some of the findings from the intraoral and extraoral exam include the lack of buccal support on the left side of his face, and this is noticeable due to the involved surgical reconstruction of his mandible and implant placements after his car accident. This also resulted in some TMD symptoms such as subluxation and crepitus on the right side. He's actually taking medication for the pain, as we've mentioned prior. His lips are dry and chapped. He has keratinized mucosa and desiccated tissue. This could be due to tobacco use, and he has a coated tongue. Intraorally, there is very heavy generalized calculus present with visible plaque and noticeable poor daily biofilm control. He has generalized staining, which could be related to the wine and coffee use, and there's diffuse generalized bleeding upon probing. so his PSR scores are listed. The probing depth is generalized more than a 4 millimeter pocket, especially in the posterior quadrants. There's a clinical attachment loss generalized of 1 to 4 millimeters on the mandibular arch and 1 to 3 millimeters of clinical attachment loss on the maxilla. He has generalized recession, and around the restorations he has periimplantitis. He's missing teeth 28 through 32, and he has some cavities present, which are also listed. While assessing his gingiva, there is generalized diffuse moderate red gingiva with generalized diffuse moderate bulbous gingiva, also localized papillary moderate bulbous gingiva. There is generalized diffuse moderate firm tissue with generalized diffuse moderate stippling. So the gingival color would be red, the gingival contour is bulbous, the gingival consistency is fibrotic, and the gingival texture is full. While assessing his gingiva, the results of the gingival assessment were that the patient has generalized erythematous gingiva with generalized bulbous margins and localized cratered papilla. There is firm and fibrotic tissue surface texture that is stippled. The gingival assessment is characteristic of a class 3 moderate periodontitis, and there's localized class 4 advanced periimplantitis in the mandibular right quadrant of the implant restorations, teeth numbers 28 through 32. The results of the gingival assessment were that and in this slide, you can see some gingival images that correlate with the gingival assessment. The first being the redness of the gums, the second being the fibrotic, stippled, firm texture, the third after plaque index showing the presence of the moderate plaque biofilm, the next showing the bleeding upon probing and the teeth that have been probed in that picture. The next one is a very classic example of bulbous interdental papilla, and the last one that's there does show some pathology, but this picture is mostly to show the gingival recession that's present. And in this slide, and again, the periodontal assessment here shows that there, in the posterior quadrant, there is some mobility, some furcation. Throughout the mouth, there's generalized bleeding upon probing, mostly pocket depths of 4, pocket depths going all the way up to 8, and that again is mostly around the implants where there's periimplantitis. And again, the periodontal assessment we would classify his condition as being class 3 moderate periodontitis, and that would be generalized throughout his mouth at 66%. And the teeth are located on the slide showing that. The probings there were 4 to 6 millimeters. There's furcation, bleeding, and mobility present with alveolar bone 3 to 4 millimeters below the CEJ. There's horizontal bone loss that's shown in the radiographs with vertical bone loss, furcation, and the crown to tooth ratio of 1 to 1. For the class 4, that is localized. So that's between the periimplantitis teeth, as we've been mentioning, that would be 13%, with a probing depth of 5 to 8 millimeters. And we also see the bleeding, recession, furcation, and mobility here as well. So the statement would be class 3 moderate periodontitis with localized class 4 periodontitis, periimplantitis, and advanced periodontitis in the mandibular right quadrant around implant teeth 28 through 32. For the AAP periodontal classification, we would say that there's plaque-induced gingival disease that's generalized, as well as a non-plaque-induced gingivitis that would be due to a possible immune response to high stress. It gives the extent of disease generalized again at 69%, and the severity is more than 5 millimeters of clinical attachment loss. We would classify this as rapidly progressive, and also we note some perioendo lesions 15 and 18. And the deformity or condition of the periodontia is periimplantitis, again, around 32, 31, 30, 29, and 28. So the 8A classification would be Class 3 moderate periodontitis with localized Class 4 periodontitis and advanced periodontitis periimplantitis in the mandibular right quadrant around implant teeth number 28 through 32 with generalized plaque-induced gingivitis and non-plaque-induced gingivitis. Due to the patient's condition that he presents with, we would have a poor prognosis. This is because of the moderate to advanced bone loss, tooth mobility, furcation involvement, and also we would say it's a poor prognosis due to his symptoms of trigeminal neuralgia and his lack of motivation and ability for at-home care. So some of the short-term goals we would set in treating this patient would be to recommend switching to a power toothbrush, but this of course is only while the patient's not experiencing symptoms of trigeminal neuralgia. We would like to put him on some Periomet to help control the bacteria, some biotine to help relieve the xerostomia. And some of the specific recommendations would be for him to brush his teeth at any time when he's not experiencing the symptoms of trigeminal neuralgia, because here we would understand that it's kind of an atypical scenario where brushing twice a day, morning and night, really is not always achievable while experiencing the pain of this condition. So I'd also refer him to a general dentist and an oral surgeon to remove the abscessed teeth and the rest and address the restorative needs. The oral surgeon would also address the implant failure. So at every appointment, we would stress good oral hygiene habits and incorporate OHI continually throughout his treatment, explain these goals to him. For long-term goals, we do want to see him on a 1-month recall appointment. We'd like to offer tobacco cessation, nutritional counseling, establish functional occlusion, which may help relieve his TMJ, TMD symptoms, to find ways in which he can manage stress, and also want to hear his concern with the stain and discoloration of his teeth. So eventually, after a state of health is achieved, we can look at teeth whitening. So for me, what I would do as a clinician, I would like to arrest the disease, reduce the inflammation, prevent further bone loss, help him maintain his natural dentition, help him with his tobacco cessation, nutritional counseling, and help him mostly with motivation and to improve his attitude to regular visits. And I do understand that with his ADA classification, he would most likely be referred to periodontitis to help with that, with those goals as well. So some of the modifiable factors is tobacco use, nutritional neglect, poor attitudes towards oral health care. His plaque index score can definitely be improved. Obviously, removal of the infected teeth and the restoration. He would need a team of healthcare providers to be able to help achieve these goals. Some non-modifiable factors is the chronic periodontitis, the bone loss that's already existing, the missing dentition that he has, his trigeminal neuralgia symptoms, and the TMD disorder. While treatment planning this patient, we are taking into consideration his attitude toward oral health, his minimal knowledge, and also his anxiety levels. So to start off, we would like to just get him acquainted with the office for the regular office visit and a consultation so he can understand where we would be able to help him and we can kind of address some of his concerns while he's going through this process of seeking oral care. This would include a full mouth series of x-rays. We would take study models so we can see where the patient's at and kind of keep his case study. We would take some diagnostic pictures and we would do the regular intraoral, extraoral exam, an exam by the dentist. We would explain oral hygiene, and eventually as his treatment and visits with us progressed, we would get into the SOP and continue the oral hygiene instruction, and then hopefully achieve a periodontal maintenance that involves 1-month recalls. Periomed was prescribed to this patient, as well as Clinpro 5000 due to the caries that were present. and his need for fluoride, as that would be beneficial for this patient, I did recommend a Crest Oral-B cross-action soft bristle manual toothbrush um, because the electric toothbrush may trigger the trigeminal neuralgia symptoms. Gave him a gum brand tongue scraper because his tongue's coated in the initial exam. And the technique here would be obviously the best method if you can, or the phones method due to the subluxation from the TMD disorder. So I instructed him to aim to brush twice a day, or really more ideally whenever he's not experiencing symptoms, he should consider brushing, and maybe to try to incorporate the electric toothbrush. It's not too much for him. So I'd also recommend Sensodyne Pronamel, the Viajet water flosser, because of the subluxation and it requires less dexterity. The gum brand interproximal brushes that don't have the metal, so just the soft rubber ones because we don't want to abrade the implant surface. And that was what we focused on at this visit here. Today the patient came in for the SRP of the upper left quadrant. Some of the successes from the last visit were that he did notice the bleeding while flossing was improved in that area where we did SRP. However, he did mention that he did have slight sensitivity, but that was expected and explained to the patient while signing the consents, and he's aware of that. We were able to complete the treatment today. He understood all instructions given and he tolerated this procedure very well and did not have any symptoms of trigeminal neuralgia. We went ahead and continued our oral hygiene instruction. His plaque index was less today, it was 54, just short of our goal of 50%. So we went ahead and reiterated our goal of 50%. So far, the treatment's been successful and things are looking like they're going in the right direction for this patient in terms of motivation and a willingness to cooperate with this treatment plan. Today the patient came in for, since the patient did mention at this visit that he was having some slight sensitivity from the areas of SRP, the over-the-counter medications that were recommended was 400 milligrams of Motrin per day following the procedure as needed, with warm salt water rinses for post-op pain. Since the patient did mention at this visit that he was having some slight Today's visit was our last visit for the scaling root planing. The patient did seek a physician's care in terms of managing his anxiety. He did take Xanax before his appointment today. He does seem to be more relaxed. The trigeminal neuralgia symptoms are controlled, and we are ready to finish the lower left, which we weren't able to due to the anxiety attack at the last appointment, and begin the lower right. Because we'll be anesthetizing the lower right, I was able to only use Oracix on the lower left, half a carpule, and the patient seemed to tolerate the procedure very well. Anesthesia was achieved on the lower right, and we hand scaled that quadrant, subgingival irrigated with chlorhexidine. The patient does seem much more motivated toward oral health through his continued follow-up calls, encouragement, and mostly due to the personal goals that he had set for himself with the plaque index and the achievement of the goals that were set. So we set a new goal after his plaque index was 15% today. We set a goal of 10%. And at this visit, things continually seem to improve. Due to his attitude toward oral care, he did express his desire to quit smoking. A tobacco cessation was given and resources were given to the patient. And a quit date was set for November 22nd. So we'll go ahead and follow up with that. And also now the patient is in a treatment of periodontal maintenance over 6 weeks. After that, his treatment plan includes a 1-month follow-up just to help arrest the disease, maintain health, and just to stay on top of this patient. Some of the home care recommendations for this patient is Periomed Rinse to help aid in bacterial management and reduce gingivitis, and ClinPro 5000 prescription fluoride toothpaste. The patient can definitely benefit from fluoride as he has caries and xerostomia present. I recommended a Crest Oral-B cross-action soft bristle toothbrush as opposed to an electric toothbrush because the patient has trigeminal neuralgia and that may initiate some of the symptoms. He presented with tongue coating, so I recommended the Gum brand tongue scraper for him. For the brushing technique, it was either Bass or Phones. Bass would be preferable with a 45-degree angle toward the gum line if he's able to manage that, but Phones may be more probable in his case due to the subluxation that he has and the symptoms of his condition. So the special instructions were ideally to brush twice a day when he's not experiencing symptoms, but any time when he's not experiencing symptoms, I encouraged him to brush his teeth. For flossing, I did demonstrate flossing with string floss, Dr. Tongue's Smart Floss. It's thicker and it may be a better option because he does have some spacing due to the bone loss in between his teeth. I did recommend that he consider getting a water flosser. I did recommend Viajet water flosser, however, any water flosser would benefit from the trigeminal neuralgia and subluxation. It would be the easier way for him to floss, and due to his lack of motivation for oral care, I did try to take into consideration what would be easiest for this patient so we can work on compliance. For interdental aids, I definitely stayed away from anything that has the metal wire for the interproximal brushes because he has implants still, and that includes the interproximal brushes without the metal, so just the soft rubber ones, and I gave him some of those. For the mouth rinse, I did recommend baking soda, especially if he experiences vomiting from the medication. Also baking soda to help neutralize the bacteria in his mouth, or biotin for the xerostomia. Because I recognize this patient can benefit from fluoride, we did do a professional application of the Vela varnish, and post-op instructions were given. Products to avoid with a hard bristle brush, anything that had a metal in it because he's an implant patient, and the electric brush only if it triggers the trigeminal neuralgia symptoms.